This is the Etiology podcast. I am your host, Elka Kubaku, licensed social worker and psychotherapist. In this podcast, we explore divisive issues around food, health, and body image with the goal of mending relationships within the eating disorder recovery professional community and creating a space where a multiplicity of perspectives can coexist harmoniously. This podcast is uncensored and encompasses the political and ideological spectrum. If you believe something you hear is harmful or misinformed, please be respectful to the speaker. And also, feel free to reach out about recording another episode on the same topic from your vantage point. My hope is that if, as professionals, we can hold each other's stories with respect and compassion, we'll be better able to do so for our clients. What happens when someone with a high acuity eating disorder needs more support than can be provided in outpatient settings, but refuses a higher level of care? Considering the high mortality rate of eating disorders, this question can quite literally be a matter of life and death. In a previous episode on harm reduction, we discussed the value of meeting clients where they're at and how high risk behaviors can and sometimes must be mitigated in outpatient settings, especially for those with treatment trauma. In this episode, we explore the flip side, the importance of acknowledging when a client's needs exceed our limitations, and at times challenging a client to seek higher levels of care despite their apprehension in the interest of preserving their safety. Psychotherapist Amber Cardemil reflects on how she navigates questions around supporting and challenging clients with treatment ambivalence. We discuss the benefits and limitations of treatment contracts, which clarify the minimum requirements for maintaining safety in outpatient settings and outline the conditions under which more intensive treatment becomes necessary. Amber also shares the nuanced, individualized nature of decisions as to whether to refer out or continue a therapeutic relationship based on the quality of rapport and individual clients' needs. Beyond the sticky, complicated ethical questions, Amber speaks to what it is to be a human being supporting someone who struggles deeply, what it's like to celebrate their growth, grieve their setbacks, and let go when it's time to move on. Amber is a licensed clinical social worker with extensive experience treating eating disorders, food-related concerns, and co-occurring conditions. She is trained across all levels of care, inpatient, residential, PHP, and IOP, and has worked in admissions, assessment, individual, family, and group therapy. She is a certified health at every size provider and has advanced training in family-based treatment for adolescents with anorexia nervosa. She uses evidence-based treatments tailored to each client with attention to individual and family dynamics. She empowers families to support recovery and collaborates closely with other providers to ensure effective multidisciplinary care. In addition to eating disorders, she treats anxiety, depression, and life transitions. Amber also provides psychoeducations to schools and universities on early detection and prevention of eating disorders and serves as a body project facilitator through NEDA. She is a member of Project HEAL and is committed to equitable treatment access. Hi, Amber. Thanks so much for joining me today.
Hi, thanks so much for having me. I'm excited to be here.
Yeah. Can you start by telling me a little bit about what you do professionally in the eating disorder recovery field?
Yeah. So I'm a licensed clinical social worker or therapist. I primarily work with individuals and families who have eating disorders. I see like children, adolescents, adults, and I also work with a lot of families. So yeah, I mean, I've been an outpatient in my practice. It's called Collective Healing for about 3 years now. And prior to that, was always working in like higher levels of care. And so within the last a few years, just kind of making my way to outpatient and learning
Yeah.
that learning that angle of treatment. So
Yeah. So you've seen the spectrum of the ways that eating disorders are addressed.
hmm
Yeah.
yeah.
We were going to talk today about treatment ultimatums and termination. Can you start by just giving a little bit of background on that topic, where it comes up, what the questions are around it, what are the different positions people take?
Yeah, yeah. So I often think that it's really difficult to treat an eating disorder on an outpatient level. And um I think when treating them can depend on a lot of, maybe the provider, and also kind of how like what the presentation of the eating disorder looks like, what motivation looks like, a lot of things. I feel like there's a lot of variables that depend on whether or not it can be treated if they're medically stable, things like that. Um, but I think as far as providers go, sometimes I think we all run into a case where maybe our hands are a little tied.
Mhm,
And where a lot of options are exhausted, where sometimes we are working harder than the client is,
mhm,
um, or we just get into, I feel like, an impossible situation where it's just really hard to know how to move forward
mhm.
in the treatment. Um,
Yeah,
so, I've kind of been on both ends of that, and I feel like there's never a right answer sometimes.
yeah. So the question, let me see if I'm understanding, is when let's say we're working with someone who clearly has a severe eating disorder, maybe is questioning whether they want to get help for it altogether. And let's say as a therapist, I'm working with this person and seeing them, for example, progressively losing weight, or other things that lead to concern. And I feel like I'm starting to bump up against the limits of what I can do with them, meeting with them once a week or maybe even twice a week if that's possible. So the question then becomes, at what point is it time to refer out or time to say you need something beyond what I can provide and I can only work with you if you're willing to get that? Is that does that pretty much capture the question?
Yeah, 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 yeah. Because I think a lot of it is, I think when I rub up against that situation, a lot of it comes down to like, what is the client willing to do to
Mm-hmm.
stay at an outpatient level? If I have this vision and this idea of what recovery looks like, then how can you meet me halfway, or how can we begin to build some willingness towards some of those goals? And if not, then like what does that look like afterwards? Like what kind of support might you need at that point?
So can you describe to me some of where you've seen this or experienced this in your practice play out?
Yeah, yeah. So I tend to see this a lot with adult patients who maybe their family is still involved, maybe in like the college age to like, I've definitely had someone before they were 30 still kind of struggling with the same um, pattern, and where I feel like I'm always willing to meet somebody where they're at. And I think just because of my experience in like higher levels of care, I'm a little more creative with like interventions.
Mhm,
And and I think I'm very good at like getting the family involved and pulling in a lot of like important pieces into helping people evaluate their recovery. And so like I think where I tend to see this show up and how it plays out is that um, I meet them where they're at. That works to a certain point, and
mhm,
then the eating disorder just becomes
mhm,
really unmanageable with a lot of these boundaries, or, if I've done a treatment contract, at the
mhm,
end of the day, it comes back to like a power struggle sometimes where um,
mhm,
I want them to get better. Maybe they don't want to get better, or they
mhm,
they they feel like they can't get better. Um,
mhm,
and then from there it kind of trickles into like me getting kind of, my hands are tied behind my back at that point, and I feel like they either need a higher level of care, to which a lot of them are not willing to go,
yeah,
or I continue working with them.
mhm,
And honestly, I don't know if the work is, you know not as meaningful for the client, but
Mm,
certainly on my end, like it feels like, over and over, I'm documenting what isn't
mm,
changing, and that doesn't feel good. Like at some point it
yeah.
feels like like I'm not serving the client in the best way.
Yeah, I really appreciate you sharing that. I know I've had the experience in therapy, maybe for different reasons, of it feeling like, okay, like we're not really getting anywhere. So it feels valuable to be able to acknowledge that.
Yeah. Yeah.
So what you're describing to me is, and I'm sure others have seen this. I've seen this for sure. You're working with a client who's ambivalent about recovery, which is often the case, especially with restrictive eating disorders, because they are their ego's syntonic. They often feel in line with what the person wants. So your starting point is I'll meet you where you're at. I'll tap into whatever you do want and try to work with that. You described also I work with you work with families. You had mentioned when we spoke previously that you do family-based treatment.
Mhm.
So you'll spend time both connecting to the person and also supporting their family to help create structure around meals. And at a certain point with some clients, you hit a point where it just feels like they have their own hesitations or blocks toward recovery that you're not really able to address, and you're hitting against the same walls. It's in some ways affecting the therapeutic relationship as well.
Mhm.
Tell me a little bit about, you had mentioned that having worked in higher levels of care, you're used to coming up with creative ways of working with clients. Can you describe some of that to me, what that looks like?
Yeah, yeah, yeah. So I think so I've used treatment contracts, which honestly were a lot of structures that the treatment centers would use, where
Mhm,
where they would sort of have a written contract of like what objectives or goals they wanted the client to move towards.
mhm,
But I've also done um like I've, for instance, like with adolescents, you can use leverage sometimes, to get them to work towards something that they really want. Not like I guess like incentives, um, but more of like if there are immediate consequences, like the parents won't let the person use the car or
yeah.
right, like something like that. Like sometimes those things do work. I wouldn't say long term they work, but temporarily they can get motivation going.
Yeah.
Um, yeah, I think I've also just like, for instance, I talk to adults a lot about like, building a life that they
Mhm,
want
yeah.
and like using that vision and that motivation as like something that they're working towards. Like you want autonomy, you want independence, but every time you use this eating disorder, like it just pulls you back into like
Hmm.
all the same dynamics that you don't want. So
Yeah.
like how do we build a life worth living? Like how
Mhm,
do we, how do we work towards that? Um and right, or even like bigger picture goals. Maybe they want to be married. Maybe they want to have a family. Maybe they want to, work full time. Maybe they don't want to be struggling with this as much anymore. Um,
mhm,
I also use frequency too. Like we can begin to space things out as you're doing well.
mhm.
And
Yeah.
right, like we can kind of collaboratively work together towards, making these bigger changes in your life. So I
Hmm.
think I do use a lot of like we're in this together and like we're gonna do this together.
Yeah.
Um, and I think I do, like I think I'm very like loyal to the client. I sort of hang on like longer than I probably need to, which is sort of my
Yes.
own hang up sometimes because I do care so much about them and wanting to like get them to the other side.
Yeah. So I hear a motivational interviewing process where it's like, let me understand what your goals and values are, what your life vision is. And when we connect recovery to those goals and visions, you're more motivated toward it.
Like building their intrinsic motivation.
Yeah. Because we're talking about those times when that hits its limit. Before we go into that, I want to share a little bit more about the times when you've seen that be effective. Um, I'm just my caution almost is when people are hearing this, I don't want them to be like, okay, like that's just an ineffective approach. Try something else. Like I hear that you've done a lot of good work with this, and I want to understand that first before we explore the limitations.
Mm-hmm. Yeah, yeah. So I guess like around like so I guess like right, like probably using the motivational interviewing type of framework. I think I'm always using like a lot of change talk. Like I'm assuming that why they're seeing me is because they do want to move towards some sort of change, even if they don't want to admit that or,
Mhm.
sort of be open about it.
Yeah.
Um, I think meeting them where they're at, like I think I'm always like assessing where they're at in in their stages of like change and kind of identifying that and then like trying to move them towards like the kind of the
Yeah.
next phase. Um, but but also just too, I think that also how I frame the eating disorder, is really that it's like this multi-layered thing. And what started it is really kind of at the core and like, and maybe that was things that predated the eating disorder, like, low self-esteem or like family conflict or issues with relationships or trauma or, whatever that is. And I also use that as like something to work towards. Like, yeah, like
Mhm.
don't you want to be stable enough to do that work?
Mhm.
Every time that the eating disorder sort of pops into the picture, like it takes you away. It's like a distraction away from like working on the stuff that you really need to.
Yeah.
And um, so even just like kind of using that and like being I think using a lot of like I use a lot of metaphors, like
Mhm.
and I think that it's something a little more comprehensible, I think, because I do think that clients feel like sometimes like, what is recovery anyway? It's like this big thing that everybody tells me about, but I don't really know like what that is or what I'm supposed to be like doing
Yeah.
to work towards it.
Yeah. So you'll also serve almost like a coach in some way where it's like we can break this down together and make it feel more tangible and accessible.
Yeah. Yeah.
Can you tell me, I know you can't describe to me specific clients, but can you tell me about like sort of a general, or if you were to like combine a few clients into one story, like where you've seen it work, where you've been with someone in that process and seen the movement from like, I sort of want this, but I'm really hesitant to like this feels more accessible.
Mm-hmm. Yeah. Yeah. Hmm. Yeah, I mean, I can think of a few where it, honestly, sometimes, I'm trying to think. Yeah, like so sometimes, right, like I feel like as therapists, like we know where we're headed to, but
Mhm.
sometimes the path to get there, we find out that we kind of have to take a back door sometimes, and right, like it
Yep.
can start off like this, and then it's like, you
Yep.
know,
Mhm.
um, and so like I'm kind of I'm used to like throwing a lot of things at the wall and seeing what's gonna stick.
Yep.
So like, sometimes it is like maybe we're working towards like something that they want to work on, like low self-esteem, and then like kind of, backdoor working on like connecting how the eating disorder and the behaviors can like strongly influence how they feel about themselves. And then right, then we might go through another door where it's like,
Mhm.
talking about anxiety, but always tying that back to the eating disorder. And I think being strategic and like bringing that into the conversation instead of avoiding how it doesn't relate and how it's kind of like this separate entity. Um,
Mhm.
but like where I've seen it play out, yeah, I mean, I think just I've definitely had clients where like honestly I'm working on maybe their mental health concern, but then I'm also working on like, maybe minimizing behavior use or maybe it's weight restoration. And I find that those two things kind of end up aligning towards the end
Yep.
where like maybe as they're weight restoring, like they're gaining more insight and the light bulb is starting to go off more. And then and then they're feeling better, they have more energy,
Yeah.
right, like they're able to tolerate more of the topics that we're talking about.
Hmm.
And the
Yeah.
relationship is so strong at that point that,
Mhm.
and then honestly, they're moving through like a lot of life changes. Like, I
Yeah.
can definitely think of one client where it was like, she got a job and like that was the huge
Yes.
thing. And then after that she got married and then she had a baby and then, right? And now I can say that she's, doing well and she would say she's doing well too. But this was
Yeah.
somebody who, day one, I was like, I don't know about this one. We'll see.
There was a moment of such joy on your face as you're describing her doing well, and that like gives me a sense for how you're relating to clients. So somebody's coming into you ambivalent about recovery, maybe they want it but are afraid to, not sure. And they're also coming in with like, I don't feel good about myself. Um, I'm too hard on myself. I'm uncomfortable in social situations, whatever it is. And they know the eating disorder is there, you know it's there. So you're like, okay, let me work on the way you're feeling about yourself. And alongside that, we'll also work on um, whatever weight restoration and there's an aspect of this that's behavioral when I hear you describing the treatment contract or where it's just like, okay, let's make this into small goals and we'll work toward them together.
Hmm.
Alongside that, there's a therapeutic relationship where you're building enough trust that they're like, okay, I'm willing to do things that are scary with you.
Hmm.
And the building self-esteem, both directly self-esteem or whatever the underlying or parallel issue is alongside. And also they can start to see that as they're doing these behavioral goals, it's starting to shift some of the things that matter to them. And that's where you see it's almost like you're starting to build this recovery momentum that makes it feel possible.
Yes. Yes.
Mhm.
Yeah, yeah. I think that they're almost like proving to themselves that, maybe something's working or maybe they're working, right?
Yeah.
Um,
I'm curious about your experience with treatment contracts. I did my internship at a PHP IOP program, and I've seen treatment contracts used. Um,
mhm,
used them a little bit myself in a situation where somebody was like, I really don't want to go to, let's say, residential or higher level of care. Can we just make a contract? And if I can keep it, like we'll stay here. Or I've seen people let's say, were using substances and reached a point where the treatment center I was at was like, if this continues, we need higher level of care. And I haven't seen a lot of success with it personally. I've seen a lot of people like really wanting to keep the contract and believing they can. And then um, whatever is compelling them toward these behaviors or using whatever it is gets in the way. I'm curious what your experience has been like that, to what extent it matches, or if you have seen more success with it.
yeah, yeah. So I think right, like I certainly see contracts as like a short-term intervention. And I think one that can be modified. And I sort of explain that, things about it are going to change. Like we can either add to it or take away from it.
Mhm.
Um, I also use sometimes a contract for, through like a more harm reduction approach. Like I did have like, for instance, client, maybe they were, maybe using a lot of symptoms and, we sort of, titrate, like 5 times a week, 1 time a week, or sorry, 4 times a week, 3 times a week, 2 times a week, 1 time a week. We're always modifying it and going over it as a form of structure.
Mhm.
So that we're also reiterating like the goals that we're working towards and the agreement that
Yeah.
we both have, that this is collaborative. Um,
Yeah.
but and right, like honestly, sometimes I find it helpful just with like targeting symptom use. But I've also seen it honestly I'm thinking about this one contract that I made for a client, where we honestly just put the bare minimum of what we expected for outpatient care. Like it was like gain a half a pound of every few weeks or something. And the client was like, no, I can't do it. And
Mm,
and that I think was very telling, not just to us, but to that person that like I can't even maintain like kind of the bare minimum here.
mhm.
And I kind of
Yeah,
need something more.
I have actually seen that now that I think of it, that oh, like allowing for the contract and making it clearly specified um, gives a kind of clarity to like maybe I do need something more, or maybe I'm not in control of this, as in control of this as I thought it was.
Hmm. Hmm.
You mentioned before that you've yourself shifted perspectives. My impression talking to you, and tell me if this is accurate, is that you started off with more of a like, I will work with anyone anytime and like I'll meet you where we are, we'll build this relationship, we'll make it work, we'll find a way.
Hmm.
And that's shifted for you as you bumped into limitations that it felt like you didn't have a way past.
Yeah, yeah. I think yes, probably one would learn from having those limitations that they shouldn't, that maybe they should be more cautious when they're taking clients. It is funny though. Like what's funny, I just think everybody's so different and everybody responds so differently to things that I don't, honestly, I haven't really changed that. Like I know that it is something I can come up against, and I think there are different ways I've learned to like manage it. And case by case, it's so different. There's definitely clients where it's like, come back when you're ready. And then
Mm-hmm.
there's clients where it's like to the end, I'm holding on with like,
Mm-hmm.
so
Yeah.
it just depends. Cause like,
Mm-hmm.
but I'm not saying that that work feels good for me because it doesn't. It pains me to say like client refused recommendations, client
Mm-hmm.
did, and I'm just like kind of taking a back seat and seeing and holding space to
Yeah.
see what somebody does. But
Mm-hmm.
but I also have to, those are also times where honestly I do a little bit of a reality check for myself and I'm like, it's not about me. It's about
Mm-hmm.
them.
Yeah.
And if this is what, if this is the space they need, then like I need to listen to that. But there's nuance with every client. I feel
Yeah.
like where I get to that point where I'm like, okay, you know what? They're resistant, maybe because I'm resistant.
Mm-hmm.
Right? And maybe I need to kind of like, I'm good at rolling with resistance, right? But like, I just mean sometimes I get into like a,
Yeah.
and then I need to kind of
Yeah.
like back up and
Mm-hmm.
and
Yeah.
give it some air.
So it's not so much that you in your professional journey move from this idealistic, like I can help everyone to maybe I need to set limitations somewhere, but more so that even now you're holding space for both of those.
Yeah.
There's
Yeah.
a
I think
space
I've
where
become
it's
more
like,
flexible,
yeah,
maybe.
yeah. This, I mean, both sides of it, the I'm willing to stay with someone until until they die if it reaches that point. We hope not. And in some cases, I feel like it would be more helpful for me to say, like, we've reached the limit of what I can do for you. Let's look for something else. What in either your personal, we've spoken a little bit about professional experience, but I guess like what either values or experiences do you bring as a person that shapes the way you approach this?
Yeah, yeah. I mean, I think that, well, years of therapy, right, for me.
Mhm.
Like I think sometimes where that comes from, like for me, like I struggle sometimes to I can feel overly responsible sometimes for things that are not mine.
Yeah.
And like, over the years I think I've gotten better with it in recognizing like what's this for me to work on versus what's
Mhm.
for them to work on. Um, and honestly, that's how a lot of relationships operate anyway, like 50
Yeah.
50. And right, like some of it is like, if I'm always like kind of coming in and doing the work for them, like what's really left
Mhm.
for them. So like, I think for me, like professionally, yeah, like I think it's parallel to my own process. Like sometimes I have to like give it space before stepping in and doing something for someone else.
Yeah.
And I try to do that for the client these days too.
Hmm.
Because I mean in the end it's not that I don't think that they can do it. I just
Hmm.
think um I guess I get worried that they won't or something and then I feel like I have to like,
Yeah.
you know, like it's my job or something. You know what I mean? It's my responsibility to like help them or save them or something and it's not.
Yep.
It's not.
Hmm. Yeah. Boundary setting. That's been a part of your personal and professional work.
Yes, yes, yeah, boundary setting. I think yeah, knowing where that is for me. And and that being said, like I think I also know when honestly I've done all that I could and at this point it's like my ethical duty to kind of refer out or you know,
Mm-hmm.
yeah, provide them with, additional referrals.
Yeah. That like this is where you end and I begin.
Mhm.
This is how much I can do for you before maybe almost approaching you too close to the point where it's disempowering, where I'm taking some of your power as my own. And
Mhm.
also, this is where my limitations are. This is what I'm capable of.
Yeah.
Can you, to the extent that you feel comfortable, you had thrown out like years of therapy. I don't know how comfortable you are sharing your own story, but to whatever extent you feel comfortable, can you share a little bit about what that was like, what the essence of your work on yourself was, and how that plays into how you approach your work with clients? Because we all have our origin story that often starts in our own treatment of some kind.
Yeah, yeah. Yeah, so probably my home life. Like I'm a middle child, like I can be a little bit of like a perfectionist, people pleaser, definitely. I was like the peacemaker in my family. So I have an older sister and a younger brother.
Mm-hmm.
And of course, my parents had like a lot of marital issues and just were like getting together, separating throughout my life. And I always felt like responsible for making sure that everybody was okay and making sure that, that my parents stayed together. Like I felt a lot of that pressure.
Yeah.
Um, and so I think as a way to feel safe, I would try to control, right?
Mm-hmm.
And then so that led to, I think, like just, being overly responsible and almost being like, growing up too fast, I think. Like
Mm-hmm.
I would
Yeah.
also feel like a parent to like my little brother or something, which like that obviously created a lot of issues in our relationship.
Yeah.
Um, so yeah, like I think it tends to show up like in that way. Like
Mm-hmm.
it's like, you know, I feel like I can really like and I do. I feel like I can really help people, but like to the extent to which, I also need to recognize like when like I've done a lot and it's
Yeah.
not my, I don't need to keep going.
Mm-hmm. Yeah. That feels like a lot of what we experience in like the codependence. Like a lot of us in the therapy world are used to taking care of people. I'm also a middle child, by the way, but of 10. um,
Oh my
but
God, 10.
yeah, I'm the middlest of all the middles. Um, but yeah, we're used to taking care of people, and that's what helps us in this field. And also, like you're describing, there's a point where like my work is to recognize where I begin and you end.
Hmm. Hmm. Yeah. Yeah, boundaries. I feel like that topic it's ongoing. Like I feel like we learn new boundaries and draw all kinds all the time.
Yeah,
So,
yeah. And recognizing also that the boundary might be, it might be about me. It might be like, this is as much as I can do. Um,
mhm.
and the boundary is what I do when I hit that limit or when you're trying to cross that limit rather than what I make you do or um, yeah, what I can force you to do to accommodate it.
Right, right. And yeah, I think too what you're saying too, like everybody just has different boundaries. Like I get a little concerned because I see in the field sometimes that there's a lot of judgment towards other people's boundaries, like in
Yeah.
how they practice professionally. Like
Hmm.
like I remember seeing like a post somewhere in like the, in one of these Facebook pages that, where somebody was describing like stop giving patients like an ultimatum for a higher level of care, just like, and I don't know if this is leading into
Yeah.
like this like topic of like incarceration and like
Hmm.
to me that
Yeah.
just feels like really radical. I couldn't even tell you I have an opinion on it, um but like, but yeah, I mean, everybody has different boundaries, and I think,
Yep.
right, like, I mean, how you draw them out is entirely up to you.
Hmm. Yeah. Yeah. And like in the therapy world, I've also seen those conversations, and it becomes, it feels to me like it becomes so tricky in general in the therapy world because we're essentially just talking about the human condition. And I feel like anytime proclaiming yourself as an expert on the human condition is it's a dangerous place to be because like you described, it's so individual. What I hear, and I've spoken to some people, maybe we can create some dialogue around this actually in a future episode, is when I hear people like don't make an ultimatum for higher levels of care, I hear people who've had really destructive experiences in higher levels of care, which does exist. Like we know there are stories of abuse, there are stories of like overly harsh measures, or even sometimes like um non what's the word like even a treatment center that's not trying to do harm. Like there have been people who've had really damaging experiences. So when I see people who are like, don't make an ultimatum for higher levels of care, I hear people who are like higher levels of care have really hurt me or someone I care about. And I don't want anyone to be forced into that.
Hmm. Yeah. 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 Which I mean, obviously, like outpatient has its, right, like has its perks. I also think a higher level of care has its perks, and
Yep.
sometimes that's needed and indicated. And, uh,
Yeah.
you
Yeah. I've seen actually patients whose therapist had been like, I reached my limit and I can't do this anymore. And that actually had pushed them to get help that they needed, like
Mhm.
that acknowledgement that, like, this is what I can do for you.
Yeah, sometimes, yeah. I mean, I've used probably that same sentence. Like the most caring thing I can do for you is to refer you to a higher level of care. Like,
Hmm.
I feel like we have tried everything, but at the end of the day, you might just need a little more support than what I'm able to give.
Hmm. Yeah.
Like you can't be everything for everyone.
Yeah. And the way you're describing it also, like, is again, like, these are my limitations. They might not be somebody else's. And if somebody else is on an outpatient basis and feels like they can work with someone high risk and in a way that feels, I don't know, to whatever extent safety can be implemented and ethical, like that's okay for them. This is what I know I'm capable of. So this
Mm-hmm.
is not a statement about the therapy world at large and what everyone should or shouldn't do. This is a statement about where I'm capable of going with someone.
Yeah. Yeah. Yeah, because everybody has like different levels of like, I think tolerance, right? Like I would consider myself to be very tolerant. I think I take on a lot of cases that honestly a
Mhm.
lot of people wouldn't. Like because I just have a lot of patience and I have a lot of bandwidth and
Mhm.
I have worked with some really acute cases. I'm
Yeah.
not just trained in like eclectic approaches, but a lot of like FBT like gave me a lot of that capacity. And so like like for me, I'm like, if I'm kind of reaching a point, right, like I can't imagine like, right, like everybody does with in
Right.
their own ways. I have people that refer to me because they don't have a lot of tolerance for a client, whereas mine might be different. Um,
Mhm.
and vice versa, right? Like everybody has a different skill set and
Yeah,
um
for
different
sure.
things that hit home.
For sure. Yeah. when you describe that difference in the way that you work with people now, where you have some people who are really high acuity and to the extent that maybe you don't even know if they'll survive, and it's just like, I'm with you on this, versus
Mhm.
some people where you hit a limit, you feel like you're bumping against a wall, and maybe there's something more out there for them. Can you tell me a little bit about how, and I don't know how like clearly systematic an answer there is to this, but what are some of the things that lead you in either of those directions with different clients?
Yeah, yeah. Yeah, so I think sometimes I think sometimes the relationship can be different.
Hmm.
Like not that I treat
Hmm.
clients differently
Yep.
necessarily, but right, like sometimes there's just something that grabs you about somebody versus maybe other ones, right? Maybe the rapport is, different.
Yep.
And yeah, I mean, honestly, maybe like within myself, I would say that I'm very like unconditional. Like I think I'm very like I try to have a close relationship with most of
Hmm.
my clients. Like they know how much I really care. And so
Hmm.
I think that they know I will extend myself a little bit to
Yeah.
help. Um, but yeah, and then obviously I think it's like severity of the eating disorders, right? Like some of these other, variables that are kind of beyond my control.
Hmm.
And like the duration of the illness, like how long they've had it and what their current support system looks like. Yeah,
Hmm.
yeah. I'm trying to think. I don't know if there's maybe things I don't know if it's like would be personal or not, some of the things that maybe, yeah.
Yeah. Yeah,
Um,
what you're describing makes a lot of sense to me and resonates with my own experience when you talk even about the rapport. Is to me, it feels like, and this is how I assess, and it's like the most subjective measure, but I think it's pretty effective for like how my work is going with a client. And that doesn't mean like refer out or not, but just
yeah.
like I can feel after a session to what extent I'm inhabiting this person's world.
Yes. Yes. How much you're
So,
making an impact,
mhm.
maybe.
Making an impact and even sharing the space with them where they feel understood and we're really like in the same space. Whereas I'll have like if somebody comes in and it feels like we're like sort of talking, but it's very hard for us to make contact, like to me that's an indicator that like something is missing. And sometimes it's personality mismatch, sometimes it is like there are pieces of their life that I haven't gotten or been able to make contact with yet, and there's space to work through that. um
Mhm.
so when you're talking about like some clients, it just feels like we're like there's a good rapport, we're in the same space, and it feels like there's a power in that, even if maybe like we don't know how they'll get better or they're really struggling. It feels like there's a value and there's some kind of support that they're receiving just in me being with them in this.
Yeah. Yeah. No, no, yeah, like this, yeah, like I think like acceptance, like this unconditional regard, like very like person-centered, sort of approach. Yeah, no, no, I agree. Or even, yeah, I think you made a good point about just maybe there's something that you're offering them that they really need deep down in, maybe it's hard to, access that in their outside world.
Yeah. When you talk about the frequency, duration, severity, how does that influence? Because what I believe I heard you saying was that there are some people with higher frequency that you might still continue working with. Some people who have high frequency that you feel like you've hit a wall with. Um,
Mhm.
is that the relationship that makes the difference? Is that like maybe somebody's been through it all already, so there's no like, do I can't refer them to higher level of care because they've already been there, or what is that?
Yeah, yeah, yeah. Well, I think sometimes I've definitely had some more chronic cases where they've just like they've been in it for so long. And not that I don't think that for the 20th time they can't get better. I mean, of course, there's always that chance. But yeah, we're like they feel like themselves like treatment fatigued
Yeah.
and um and right, like honestly, they never really get to outpatient care. I definitely get people like that. Um
Mhm.
and and right, like and I think also too, like I was gonna say like behaviorally also, like I definitely have clients who um, they run into like dynamics maybe with maybe with like the therapist. Like I've had clients who are very avoidant and then so they just sort of avoid the relationship altogether or
Yeah.
um and really avoid like kind of getting they don't think it's that severe.
Yeah.
um, so they don't get help for it. But even, yeah, with I think those the frequency and everything, I think just like I have clients that, maybe they have outside factors why they can't come as frequently, like cost, and then that just prolongs the eating disorder because they're like not getting the help that they need
Yeah.
and they need it.
Mhm. Yeah. So this is where it feels like there's a little bit of a bridge between what you're describing and when someone's like, stop providing ultimatums, or is like if somebody's had that maybe harmful experience of residential or has been in and out of residential PHP programs for the past 20 years, and they're just like, I can't do this anymore.
Mm-hmm.
That's where you're like I'll hold space with you, or I'll enter that space with you.
Mm-hmm. Mm-hmm. Yeah. Yeah. Yeah, yeah. I mean, as long as they're open to it. I mean, sometimes they do have to discharge and kind of take some time off and figure out what they want and reevaluate. And, they do know that I'll probably check in like a few months later and sort of be like, hey,
Yeah.
how's it going?
Mhm. Yeah, you have that kind of persistence.
Yeah, just just, how are
Maybe
you
that's also maybe that's also a middle child thing. Just like
doing?
very subtly and gently, like just
Yeah,
keep
like nudge.
yeah,
Family. That's
yeah. Um, can you tell me about the first time or times when you've had to terminate a client and what that process was like for you?
Oh, oh man, that's always so painful for me. Like you mean when they don't want to be in treatment, kind of.
Yeah, or you've hit the limit, you've made a recommendation for them, they're not able or willing to follow through with it, and you're like, I've reached the point where I can't help you anymore.
Yeah, yeah. Well, honestly, I would be honest that it's been a while since I've had to do something like that, but I will say um yeah, I mean, I've definitely reached that point where I'm thinking about a case where I had to like do like a contract and the
Mhm.
person um yeah, I mean it was that bare minimum contract. I gave them the bare minimum and the dietitian that was in the picture gave them the bare minimal requirements and I think for that client we sort of said like take 2 weeks, think about if this is what you can do. If not, like let us know and we can talk about kind of like next steps. And I mean, this client really did need a higher level of care.
Mhm.
And so, yeah, we got to this impasse where it was kind of like,
Mhm.
the recommendation is for you to seek a higher level of care at this point. And whether or not she wanted to follow through with that, it's on her, right?
Mhm.
But that was sort of like this is where it has to end. Like I had been working
Yeah.
endlessly with this person for like 3 years. So like
Mhm.
it came to a point where it was like there's not much more I can do. Like
Mhm.
and
Yeah.
honestly it's funny, the dietitian was the one who sort of was like, you've literally done everything, Amber. I'm like, oh, that was hard. Like when it's bad when like I'm crying or tearing up, telling the client that I care about them and like I want nothing more for them than to get better. And then the client's sitting there stoic.
Oh.
Like, yep,
Mhm.
And yeah, that was hard. That was super hard because yeah, I mean, I think sometimes there's like we want to hold space, but sometimes we can't.
Mm,
I couldn't also equally watch her continue to like keep going down the road. Like that was that's where like again it feels like I'm not doing good work. Like, how do I live with myself? Kind of like just like, oh,
mm.
like clients refusing and I'm just documenting that time after time and time after again. Like, yeah, I don't feel good about that.
I care about you too much to watch you die, essentially.
Yeah. Yeah. Like I've done it and that was hard, but
Yeah.
I try not to get to that point,
Yeah.
as much as I
It,
can.
it
But
was pain. It was painful to terminate.
yeah, yeah. And this was an adult client. I mean, I think this is where I run into it, right? Where it's like you can't force them to go into treatment. You can't, you know what I mean? You're helpless as far as like how you can reach them. I mean, like there was leverage maybe with the family, with this
Mhm.
person going to college and, but there were family dynamics there too, that it was like
Mhm.
they didn't want to intervene. So
Yeah.
it was just hard.
Can you give some more or describe some more of the emotional texture to what you were experiencing in the moment when you're sitting in session with this client? You're starting to tear up.
Yeah.
What were some of the feelings coming up for you?
Yeah, yeah. I mean, I think I can be stubborn, I will say. So yeah, I think it's like, oh my God, I literally met someone who was more stubborn than me. Like, oh, you know.
I'm telling you, this is middle child. My husband is
Ah,
like, you're a good parent. We were talking about in order to be a good parent, you need to be more stubborn than your kids. And he's like, you're a good parent because of that.
I know, because it's like, man, like I think I'm pretty reasonable. Like I'm very much like gentle voice one, two times, and then after like the fifth time, I'm like raising my voice, right? Like it's like you have to
Mhm.
get me to that point. But but yeah, so I think I can remember kind of getting to that point where it was like I feel like I've given so much of myself and
Yeah.
and it's like not enough to want this person to get better, but not just that, but it's also just like um I think the treatment wasn't enough, right? And I think that the time spent and everything like at the end of the day like she had her own hang-ups and that was, I imagine that must have been hard for
Mhm.
her. Um but
Yeah.
I also believe that every therapist serves a different purpose on a client's journey. And if
For
I
sure.
was the person that got burned after giving a contract and this person didn't want to go, then like maybe I just set her better up for the next one. Who knows?
Yeah. Maybe she found someone after who was able to meet whatever was getting in the way then. So,
Yeah. Yeah.
yeah. When going back to like what the emotions you were experiencing,
Yeah.
I hear there was sadness, like of like what's going to happen to this person who I care a lot about. Also, maybe some almost like a softer version of anger, which is a signal that I've crossed my boundary.
Yeah.
I've extended myself past the point where it feels within my competence, within what I'm able to hold.
Yeah. Yeah. Yeah, yeah, I think that like because I think that it's actually hard for people to be flexible. So the
Mhm.
fact that I am flexible until I'm not, right? Like is sort of like
Yeah.
something for me, right? Um
Hmm.
yeah, because I think I always try to meet them where they're at. I always try to
Yeah.
check myself in those dynamics and see
Mhm.
how I'm landing and yeah, so definitely and yeah, obviously just sad because the relationship was coming to a point where, like
Hmm.
I wasn't being helpful at that point,
Yeah.
and she needed something more and right? And
Mhm.
then there's also just like a little bit of like, yeah, maybe like anxiety, like
Mhm.
too, like having a lot of, maybe judgment towards myself as a provider, like
Mhm.
like I'm literally about to discharge somebody who I don't know where they're going,
Mhm.
you know?
Yeah. There's some guilt or shame there. Like, can I do better? Which I feel like
This is funny. Like the like I'm listening to you like reflect back to me about the emotions and I'm just like I literally help people identify these emotions all the time and then it's hard for like
yeah,
me to identify them in that moment, It's just
of
funny.
course. Yeah. And it feels helpful for me, like acknowledging that now, because I feel like it's so common for us as providers who are like we want to help people to almost like override our own, like, hey, I'm supposed to be in the helping profession. Like maybe I should just keep doing this. And to feel bad when we can't like live up to the values or goals that pushed us to enter this field.
Yeah, yeah, I think we're coming up against them all the time,
Yeah.
and I think that these cases for me like happen far and few between, but they do happen and like even past just, showing up to a session, like it does impact me on a deep level. Like how could
Yeah.
it not, Um,
Mhm.
and I think that's what clients don't like know sometimes about providers is that like we do. We like, you know what I mean? Sometimes I think about what I'm going to talk to a client about, like when I'm like getting a shower in the morning, when I know I'm going to get in the office. I'm like, oh, I'm going
Yeah.
to ask this person this and this and this. And I think I
Yeah.
do a good job of like not taking it home all the time, but like, there are times here and there when, something it resonates with me and kind of sits there for a little bit.
For sure. Yeah. What do you want to leave us off with? Um, Whoever is listening to this, if there are providers listening that are questioning whether maybe they bumped against their limit, when to hold on, when to leave,
Yeah,
or
yeah.
maybe if there are clients listening to this who have been given a treatment ultimatum or feel like they're reaching that point. It's like too many people to speak to in one sentence.
I know, I know. Well, I
World
think
with.
yeah, I think just like this blanket statement of like it's okay to have boundaries,
Mhm.
like no
Yeah.
matter what they look like. I mean, to each his own, you know.
Yeah.
Um, yeah, I mean, I think it's okay for you to express your best judgment as a clinician and to know that that's right, like you're doing your best.
Yeah.
Like
Yeah.
I think in every given moment, like we're all doing our best.
Yeah.
So.
Yeah. So much. Where can people find you if they are interested in learning more about your work or connecting to you?
Yeah, yeah. I mean, more than welcome to check out my website, collectivehealingtherapy.com.
Mhm.
I one day will get on social media, but that's, I don't know. That's pending. I'm deciding how I feel about that on a personal level.
Yep.
Um, and otherwise they can always like, reach out via email or, my phone number. So,
Yep. Yeah. Thanks so much, Amber.
yeah, yeah, no, thanks for having me.